Hi everyone, my name is Jackie Berknes-Gartman. I'm a GI and liver pathologist at Johns Hopkins, and today I'm going to be discussing inflammatory fibroid polyp. This is a relatively uncommon benign mesenchymal neoplasm that most often occurs in the stomach but can occur elsewhere in the GI tract, including in the terminal ileum. So let's go ahead and get started with our first case. This is a gastric polypectomy specimen, so we can see that the surface is lined by our gastric mucosa, and then the majority of this polyp is made up by this expansile lesion that's located in the submucosa. So let's go to higher magnification and we'll look at each of these components. So starting out with our surface here, we can appreciate our gastric glands. I don't really see any parietal cells here, so I would interpret this as likely from the antrum or pylorus. We do have some reactive changes. It looks like we've got a bit of smooth muscle stranding, possibly related to some prolapse. But this is all secondary changes, and I'm not seeing any dysplasia or neoplasia involving the surface epithelium. So let's go to the submucosa, which is where our main lesion is located. And we can see that we have a spindle cell proliferation that has kind of a swirly appearance to it at intermediate magnification. We can start to appreciate some small lymphoid aggregates in here, and as well as likely some inflammatory cells admixed in here. And going to even higher magnification, we can now see that we have these very bland appearing spindled cells, but so by bland I mean that they don't have any features concerning for malignancy. They have open chromatin and prominent nucleoli as opposed to hyperchromatic nuclei. Not particularly crowded. I'm not seeing much in the way of mitotic activity. No necrosis. So overall, looks like a benign lesion. The other thing I can start to appreciate is our inflammatory infiltrate that we started to notice at intermediate magnification. So zooming in a bit more, we can start to see that there are numerous eosinophils in here. And this is a bit of a light stain, but we can appreciate our eosinophils. So for instance, here we have an eosinophil that has the typical bilobe nucleus and eosinophilic granules in the cytoplasm. And we can see that there are numerous eosinophils throughout this lesion. And if I were to scroll around, we'd see the exact same thing elsewhere. Another thing that's interesting about this lesion is how it tends to swirl around blood vessels. So here we have a blood vessel in the middle of the field, and we can see that these spindled cells are swirling around it, and we refer to this as onion skinning. So again, our classic features of inflammatory fibroid polyp are going to be this benign spindle cell proliferation with admixed inflammation, often with prominent eosinophils, and these onion skin formation around blood vessels. So if I wanted to further support this diagnosis, I could do immunostains. Inflammatory fibroid polyp is classically diffusely positive for CD34, and the stain is also nice for highlighting those areas of onion skinning around vessels. I will say that larger inflammatory fibroid polyps, for whatever reason, can actually be negative for CD34. So lack of CD34 labeling does not exclude this diagnosis, but it's helpful if it's present to kind of support your diagnosis. If you're worried about other types of spindle cell lesions that can occur in the GI tract, we could do additional stains. So this would typically be negative for CD117 and DOG1, which are markers for gastrointestinal stromal tumor. It could have a bit of labeling for SMA, but is going to be negative for Desmond if we're thinking about leiomyoma. And it should be negative for S100 if we're thinking about schwannoma. The lesions I mentioned in that differential also more commonly will occur in the muscularis propria as opposed to in the submucosa, but they are still things to consider. All right, so let's move on to one other polypectomy specimen. So this is also a gastric polypectomy, so we can see our gastric mucosa at the surface, and here we have our submucosa. Going to higher magnification, we can see again this mesenchymal proliferation with abundant admixed eosinophils. If I use my imagination a bit, maybe a little bit of onion skinning around vessels here. So this one was kind of smaller, may not have as well developed of features, but a CD34 stain, if positive, would help to support this diagnosis of inflammatory fibroid polyp. I will say we do have some admixed adipocytes in here, and I just interpret this as some of the background submucosa as opposed to part of the lesion. So inflammatory fibroid polyp, in terms of molecular features, tends to harbor PDGFRA mutations. It is typically sporadic, although there are rare reports of this occurring in patients with familial PDGFRA mutations, germline mutations, I should say. And this is adequately treated with a polypectomy, so both of these patients would be cured. And that is our 2 cases for today of inflammatory fibroid polyp. Thank you for listening.